Hello and welcome to my talk. Today I'll be covering the topic of medical oncology and ocular melanoma and give you an overview. These are my disclosures. So, ocular melanoma in Australia was a little bit of an unknown, but more recently we've got some very good data out of the group from Perth, which really quantified the impact of the disease and the patterns of care in the country. From 1982 to 2014, there were 5,087 cases of ocular melanoma diagnosed in all Australian states and territories. The average age standardized incidence was 8.3 people per million population, which didn't really change much over that period of time. And that number is probably slightly higher in Australia compared to other Western countries. The average 5-year survival also hadn't really changed. It was over time, it was about 81%. There are a number of gaps in the treatment of ocular melanoma, many of which you will all be aware of. We don't really understand the risk factors for ocular melanoma beyond a relatively crude understanding. We don't have the best treatments in terms of vision preserving treatment for patients that have ocular melanoma. We don't necessarily know how to risk stratify patients to understand who has dangerous melanoma and who has more benign ocular melanoma. We certainly don't have any treatments to help prevent the melanoma coming back before we can find it, nor do we know how intensely or how often to survey patients to pick up the ocular melanoma as soon as possible. And we certainly don't have a good grip on treatments for the melanoma once it's spread. How are we going to make progress? Probably in understanding things called biomarkers, remnants of the melanoma, things we can pick up to find the disease, understand the disease, and then use them to treat the disease. If we just start with a primary disease in the eye, there's a number of ways to understand that disease in the laboratory to help give patients more information. You can biopsy the melanoma with a needle. That's a somewhat difficult procedure at times and often isn't done in the Australian setting. If you do biopsy it, you can look at it under the microscope, you can do some analysis to perhaps help understand whether that melanoma is a dangerous melanoma. If the eye is removed, however, certainly you can have a good look at the tumor. You can take some DNA and do some DNA analysis to get a much better idea of the risks of that melanoma coming back over time. There are, however, a number of problems with the diagnosis or even the monitoring of ocular melanoma. Mitch Stark has done some fantastic work looking at something called microRNA in the blood that can help differentiate a benign lesion in the back of the eye from an ocular melanoma, which require more aggressive treatment. This recent research paper is only now finding its way into the clinic and will certainly potentially have an impact within a few years' time to help ophthalmologists make that differentiation. Ellen Gray has been doing some fascinating work on circulating tumor cells, which are what they sound like. They are bits of the tumor that are circulating in the blood that you can pick up. Now, if you have an ocular melanoma in the eye and putting a needle into it is not possible for whatever reason, you may want to get a circulating tumor cell analysis to see if that's a dangerous ocular melanoma or not. Again, this is something which we hope to bring to the clinic in a research setting in the not too distant future. Now, recently, the National Comprehensive Cancer Network in the United States put some guidelines together for understanding how risky an ocular melanoma is, as well as giving us some guidelines about how to monitor patients. Now, you can see from some of these points here that I'm indicating, some of these things you can see under a microscope, and some of them relate to the size of the tumor, which is very easy to assess. However, some of them are much more complicated and relate to the DNA inside the cancer. And once you, however, understand where a patient is on that spectrum, you can then tailor your surveillance schedules with different types of scans to work out how likely it is for the melanoma to come back, and then work out what you're going to do about it in terms of watching them with scans to make sure you pick it up early so patients can be treated. In Australia, we don't generally have necessarily some of the more advanced technologies. We have that they have in the United States. We have some very good technologies that can give you a very good idea of the risk of the melanoma coming back. Certainly, if the eye is removed, we have a technology called cytogenetics, which looks for missing bits and pieces or gains of chromosomes. Certainly, the most important of which can be loss of chromosome 3, which has a gene on it which acts as a brake to stop the melanoma growing. So that's missing, you're missing your brake, and the melanoma is more likely to spread. There's also another technology used in some states, and this does vary from state to state, called MLPA, which looks at the chromosomes, albeit in a different way, to also give you some idea of prognosis. So once you understand how risky the melanoma is, and I've suggested to you that will vary depending on where the melanoma is and how likely it is possible to get a piece of the melanoma out or look at it under the microscope in the lab, you then have to decide how to monitor patients and with what tests you're going to monitor patients. Generally speaking, the two best tests that are available in Australia are MRI scans of the liver and PET scans. MRI scans are not paid for under Medicare. However, PET scans are, and you can talk with your oncologist or your ophthalmologist about what the best test is for you. Here we have some numbers indicating, in terms of how accurate those tests are, that they're both MRI scans and PET scans are pretty good, certainly compared to what we used to do in the past, which was to take a blood test and or do an ultrasound. So what we don't know is necessarily how long to monitor patients for. We do know that uveal melanoma may continue to relapse for many decades following an initial diagnosis, and some significant percentage of the deaths from ocular melanoma occur decades out from the primary diagnosis. There seems to be almost a linear continuation of recurrence over time, and even beyond 10 years without a drop-off, as there is with some cancers where the cancer simply doesn't come back after 2 years. What we do know is that perhaps well over 50% of patients, of high-risk patients, have relapsed at 5 years using MRIs. And so certainly concentrating your surveillance in that first 5 years is probably the most appropriate thing to do. But certainly beyond that time as well, it was probably necessary to monitor patients closely. What else can we do to monitor patients? So Ellen Gray in Perth has been a pioneer of using a thing called circulating tumor DNA, which I'm sure we'll hear about later, to monitor patients. And circulating tumor DNA is what it sounds like it is, bits of the DNA which have escaped from the tumors which grow and die and grow and die, which we can pick up in the blood and then do an analysis of to see if they're present or not, to give us an idea if there is melanoma in the patient. And you can see here how that's illustrated, that the circulating tumor DNA may even pick up bits of the tumor in the liver well before they're seen on the scan, or indeed lead to a scan being done. So after the issues with regards to surveillance, the main issue that we're facing is that of understanding how to treat the melanoma if it's spread. And there's generally 2 or 3 different types of treatment. The first one is just to give treatments to the liver directly, because that's where the melanoma is most likely to come back. And there's a number of treatments that are available globally. In Australia, we tend to use some of those ones which are in red illustrated on the slide, either just blocking off the blood supply to a tumor, giving some radioactive microspheres into the liver which stick to the tumor and radiate it, or giving some chemotherapy directly into the liver. All of which are good options, and because they're just treating the liver, don't expose the patients to a lot of side effects. The other way we treat cancers is to stop the wheels turning on the cancer growing. Now, in ocular melanoma, the trouble is we don't necessarily have an accelerator. What we have is the absence of a brake, and that is called a mutation in these genes called GNAQ or GNA11, as well as a number of other mutations which sit on top of that. However, we don't as yet have brakes for those, a way to reinstitute the brake for those genetic mutations. And what we've been trying to do with different drugs, illustrated in red, is to block some of the machinery which occurs further down from those genes. Now, generally speaking, as you can see on those slides, blocking one gene hasn't been that successful. And now the field has moved on to blocking 2 or even more genes with different drugs in order to further stop the melanoma growing. The most recent iterations of this involve a gene here called FAC together with a gene here called MEC, and giving 2 drugs there, or a gene up here called PKC together with a gene here called MEC, giving those 2 drugs to see if they'll block the melanoma from growing. Results of those trials are still in progress, and I'm sure I'd be happy to tell you about them when we hear some results in a hopefully not too distant future. The third and final way we treat ocular melanoma is with drugs which turn on the immune system to attack melanoma. And the reason why that's so interesting is because in cutaneous melanoma, it works very well. Now, generally speaking, there's 2 flavors of treatment. One is to give a drug by itself, the other is to give it 2 drugs in combination. So the most common way to do this is to give a drug called a PD-1 inhibitor. The way I explain this to my patients is that the tumor cell puts up a force field which keeps the immune system out. These drugs, called nivolumab or pembrolizumab, dissolve that force field so that the immune cells, here indicated by the T cell, can get in to attack the tumor cell. However, there is another type of immune therapy with a drug called ipilimumab. Ipilimumab acts here as a master switch. And what happens here is that the human host will pick up a bit of melanoma and show it to the T cell and tell it to attack. But after a while of doing that, the T cell gets tired and turns itself off. The drug ipilimumab stops the T cell turning it off and therefore acts as a master switch to activate the entire immune system. Now, giving one drug by itself hasn't been that successful, as you can see from this slide. The chance of the tumor shrinking significantly range between 0% and albeit up to 30%, but probably generally in the single digits. Most recently, and just published a couple of weeks ago, was a study from MD Anderson where they gave both drugs in combination. Now, unfortunately, this is not available on the PBS in Australia. And if you are in such a position, you should talk to your oncologist about ways or trials to get onto. But nevertheless, let me just talk through this because it's of interest to the community as a whole. If you give both drugs together, the response rate, the chance of tumor shrinking, is probably a little bit higher than it was by giving the drug by itself. As you can see here, up to 18% of patients had a response, either a complete response or a partial response. And we say partial response means the tumor shrunk by about 30%. Some of them, however, also had a significant amount of stable disease and the tumor didn't grow, and maybe there was a bit of back and forth between the immune system and the tumor. You can see here how much the tumor shrank. These tumors grew 180% and these tumors shrunk 100%. You can see here the chance of the patients being alive over the course of time. And what's nice to see is there seem to be some patients that stayed alive for a very long time. Can we work out who is more likely to respond to the immunotherapy? Not really. It didn't matter if you had side effects or you didn't have side effects. It didn't matter how much the cancer had spread. There was a suggestion that your tumor was more likely to respond if it was outside the liver, but we don't know for sure. But what we do know is if giving both drugs together, the chance of having side effects are very high. So any side effect, 50%, something definitely related to drugs, 40% for severe side effects. And most of that was inflammation because the immune system was just turned on and wasn't told exactly what to do. So as a result, some patients got diarrhea and liver inflammation. But nevertheless, this is an advance and it is an unmet need, certainly in Australia, for our patients to have access to these drugs. One of the newest drugs, and one we are very hopeful about, is called tebentafusp. This drug works in a slightly different way to the way I described previously, in that the drug binds to something called GP100 on the melanoma and has this spiky thing sticking out. And any immune cell that happens to fly past gets turned on and told to attack the melanoma, which is between the, which sits just over here, that the little drug has bound to. Now, why are we so optimistic? Because in the first 19 patients that were treated with this drug, the partial response rate was 18% and the stable disease rate was 53%. There were even up to 41% of patients who had stable disease for over 6 months. So this is clearly relatively unprecedented in the field of ocular melanoma, and we're all very excited about a study which has just been completed, and some of you may have participated in, which tested this drug in ocular melanoma formally in hundreds of patients so the drug could be approved for sale and made available. Here's some indication of the tumor shrinking on that drug. And here's an indication of how long the patients were alive for 62% of patients were alive at 1 year, which is much better than what we would expect, which would be down here. And again, what's nice to see is that this line towards here is flat, suggesting that the proportion of patients who were alive was constant and patients weren't dying frequently. What was interesting also is that if you had a rash, you're more likely to respond to the drug for reasons we don't understand, but it certainly is an interesting observation. So I'll just wrap up by saying ocular melanoma is a significant unmet need. Prognosticating, i.e. understanding what's an aggressive melanoma and non-aggressive melanoma, is well characterized overseas, but to date has had limited integration to standard Australian practice. Biomarkers, bits of the cancer we can understand and analyze, will be key to helping patients with ocular melanoma. And I talked a bit about circulating tumor cells and circulating tumor DNA. Treatment to date for advanced disease has been relatively limited of effectiveness, but advances are consistently being made. And there's almost papers in the scientific literature monthly describing new ways to attack ocular melanoma. So I remain very optimistic. And thank you all very much for your attention.